Okay, welcome back, everyone. Let me see if I recognize all these smiling faces. Yes, I got some return people from yesterday. Excellent. Well, listen, guys, thanks for returning for day two. I know day one, we had a lot of great content, great information. Um, we're going to do the same thing today. We got some great speakers. They're going to be sharing out some information. Um, Dr. Wilson Compton is the Deputy Director of the National Institute on Drug Abuse. He's going to be talking about marijuana use among youth and adults. So it's going to be an update on cannabis science. And with that introduction, I am going to turn it over to Dr. Wilson Compton.
Well, thank you very much, Doug, and I really appreciate the opportunity to join you all remotely. It's one of while the disadvantage of this bizarre world that we've been living in is that we have to do this remotely. But the advantage is I'm here in DC and you're scattered across Maine, if I understand right, and probably other locations. So it does allow us to come together for at least the next hour in a pretty efficient and hopefully an effective way. I've got about 30 minutes of a formal presentation, but I hope that it will inspire a lot of questions on your part. And so save your questions, either put them in the chat area if you want to write them down while I'm going along, or save them up and we'll have about 10 or 15 minutes at the end for some discussion. Which I was saying earlier is always my favorite part of doing this. Okay, my goal this afternoon is to talk to you about cannabis science, and particularly with an emphasis on the impact of cannabis or marijuana on youth across America. But before I get into that, I like to remind you about how I approach these issues of substance use. And of course, we're thinking about how do these substances affect the brain? My main focus will be how do they create the harms related to changes in behavior? How do they create addiction in particular? And some might say, well, it's a product of our biology. We know these things run in families, and of course they do. Others would say, no, it's all about the environment. It's all about what's going on in our neighborhood, what's going on in our families, what are the laws and policies. And of course, that would be true as well. It turns out that it's the combination of our innate biology, our response to the environments that can lead to the very serious consequences related to drug and alcohol exposure. So it's that interaction that is both at the heart of understanding the onset of addiction, but also what we can do about it. Because I can't really change your biology. Not much. I can change a little bit with medications, but for the most part, particularly when it comes to the issues around community coalitions, we're talking about changing the environment as a way to make a major impact on the onset of addiction. Now, as if that weren't complicated enough, we need to, of course, be thinking about the age of onset. And what I've got highlighted at the bottom is just how the brain develops across adolescence, reminding us that drug use starts during adolescence, which we all take for granted, but that's not a given. Why doesn't it start at age 5 when kids learn to explore other parts of the environment? Well, it doesn't because our brains are not primed to respond to substances in the same way at those earlier stages. And the response to rewards matures fairly early in adolescence, but decision-making and judgment matures later. So that helps us understand why adolescence is a particularly exquisitely risky period of time for the onset of substance use and indeed many of the consequences. But I'll come back to that a little bit. That's by way of sort of the general way I approach these issues of drug use and addiction in our country and as a researcher. Now, cannabis or marijuana is the most commonly used illicit drug in the US. While you all know how common it is, one of the numbers I want to point out to you is that about 3.5 million Americans used cannabis for the first time in 2019. That's when this is data from the 2019 National Survey on Drug Use that was released in 2020. And that's about double the number of Americans that were first exposed to cannabis just 10 years ago. So we know that more and more people are being exposed to cannabis in any given year. We can look at how these rates have changed overall. And what we see is that past year use in the general population has been increasing. It's almost double what it was about a decade ago. When we look at use disorder, that's how many people have a diagnosable substance use disorder related to cannabis. That has increased a bit, but nowhere near the amount that use has increased. But we have seen initiation, so the numbers of starting cannabis have been going up as well. Current cannabis use is prevalent in all age groups, but notice that this graph would suggest that the increases are particularly for adults. So whether that's young adults ages 18 to 25 or those ages 26 and older, that's where we've seen the most increases in current cannabis use. We see high rates of use among the 12 to 17-year-olds, but those rates have been relatively stable in recent years. Maybe a slight increase in the most recent data that, of course, we're concerned about and we'll be tracking when we have new information coming out. Now, I just told you that we aren't seeing nationally the rates go up among youth, but what about use of cannabis by adults? Well, one of the interesting studies that I was part of a couple of years ago was a project where we looked at what does parent drug use do in terms of predicting their offspring substance use. And so within the National Survey on Drug Use and Health, there are a large number of dyads, so both a parent and a child from the same household that are interviewed. And what we saw was a strong correlation of marijuana use, that's on the left, by the mother, whether that's in the current year on a weekly basis, that's the purple lines, or during the past year, but less often than weekly, that's green, or not in the past year, but previously, compared to those that never used cannabis, that their offspring are much more likely to be using cannabis. But also cannabis use by the mother is associated with higher rates of tobacco, alcohol, and even opioid misuse in their youth. So as we're seeing increasing use of cannabis by adults, this may indirectly have an impact on their current or future offspring. We see the same findings for fathers' marijuana use, although not quite as strong. And so there is something particularly concerning about maternal use of cannabis as being associated with greater rates of substance use by their offspring. Now, some other work that we actually just published last month looked at if you're a teenager, 12 to 17, or a young adult, 18 to 25, how long does it take to develop a cannabis use disorder, to develop abuse or dependence on cannabis after you first start using it? And what we see is that overall for the teens, they are more likely to develop a disorder. That means serious problems related to cannabis use quite rapidly than the slightly older. And so this is further evidence that cannabis use by the teenagers, by the youngest in our population, is a particular concern. They're more at risk for developing a cannabis use disorder than even those who are aged 18 to 25 when they first start using cannabis. You all are well aware that the laws have been changing, while this represents a major shift in the policies and approaches to cannabis all across the country, it also means that the attitudes toward cannabis are changing. And so this may explain some of the increasing use of cannabis in many parts of the country. Now, I got this map just a month ago, but already we see it's outdated as we see just New York State and Virginia changing their laws just within the last couple of weeks. So this really is a rapidly evolving situation. Nothing has changed on a federal basis. So cannabis remains illegal under federal law. That certainly represents the dichotomy of approaches and reminds us that we're not, while we think of the United States as one country, we're really 50 separate jurisdictions that are part of a single entity. And so paying attention to what's going on in the states has a major impact. This has been associated with changes in the kind of products that are being used by both youth and adults all across the country. So just looking at this data from Colorado is a reminder that as adult use has been increasing in Colorado, we've seen a marked increase in the use, not just of combustible or burned cannabis products, but particularly the concentrates. And so that's that green bar in the lower left-hand area where we see increasing sales of these extraordinarily high potency cannabis products in Colorado, and indeed in many parts of the country. I don't know personally the situation in Maine, and so I'd love to hear from you all what you're seeing in your local area. Cannabis contains many different chemicals, and I just highlight this for you to remind us that while we will mostly be concerned about THC, that's the primary chemical within the plant that is associated with the intoxication and high with it, but CBD or cannabidiol has been of great interest as well, and certainly we see that being sold all around the country with for a variety of reasons. CBD is not an intoxicant, but it actually may have some uses, and the changes in CBD content in the plant may be associated with some of the increasing harms. And I'll come back to that in just a moment. As I highlighted for you, the concentrates represent the most extreme form of a high potency cannabis product. But even when we look at combustible or plant cannabis, we have witnessed an increasing potency of the plant products over the last now 25 years. This is data coming out of the University of Mississippi program, where they test cannabis that's been seized by law enforcement around the country, and then it's sent to Mississippi for analysis. And what they've observed is a continuous increase in potency across this time. And this doesn't even represent some of the products that are sold in dispensaries that may be legal under state law, where the potency we know is even higher than these 15–16% that we're seeing on average in the products that are seized by police across the country. But notice, in addition to the THC levels increasing across the last 25 years, we see that levels of CBD have dropped by about 50%. So they dropped from around 0.5% as their potency 25 years ago to somewhere between 0.10 and 0.24. So it's about half the level of CBD that we saw just a few years ago. Does this matter? Well, it sure looks like it does. As we see the potency increasing, we've seen on average that the chances of somebody being diagnosed with a cannabis use disorder has increased. So it appears that the higher potency is associated with greater onset of the cannabis use disorder, or an indication of addiction to cannabis, and certainly serious harmful consequences. What else have we noticed with the increasing potency of cannabis? Well, we've noticed in California that acute admissions to an emergency department have increased markedly. This is data coming out of San Diego emergency departments showing that primary and secondary diagnoses related to cannabis have skyrocketed in the last 10 years. And these include diagnoses for accidents, hyperemesis, which is a medical term for extreme vomiting, even strokes or cardiovascular disease, psychosis, and particularly psychiatric symptoms like panic attacks and extreme anxiety are some of the reasons people are seen in emergency departments because of acute reactions to cannabis, which may be particularly significant with the higher potency products. We know from multiple studies that cannabis can worsen memory. So while people are using cannabis, they're not forming memories as well. Well, that's a problem for a 17-year-old or a 20-year-old who, for the most part, their job, so to speak, is to learn, is to be in school. And so a worse memory can definitely impair learning behavior. The good news is that if people stop using marijuana, these short-term, these memory impairments do seem to resolve. So notice on the right that those green lines show that when they're abstinent for 28 days, their memory gets back to normal, to be the equivalent of the comparison group. So that's good news that we can see improvements in cognitive or brain function with abstinence. Now, here's a very interesting examination of what we think of as sort of a natural experiment. There was a university in southwest the Netherlands, nestled in between Belgium and Germany. And this very large university was had a large student population. And notice what they have graphed here are the grades that wax and wane in different academic periods. But they have two different groups here. They have those that are from the local area. Those are DGB. So that's Germany, the Netherlands, and Belgium. And then they have other students there, and that's a large university, so about half from the local region and about half from other parts of Europe or international. The local marijuana dispensaries in that area were told that they were not allowed to sell to any foreign students at some point. And so this interesting study was able to then look at what happened to the grade point averages of those who were not allowed to purchase marijuana compared to those who were. So marijuana, cannabis was prohibited to foreigners at this one time point. And what we see is that the grades for the foreigners, that's the solid line, suddenly were better than the grades for the local students. We did see that later on, marijuana was prohibited by sales to everyone at some point in this local area when the dispensaries essentially went on strike and said, well, if you're going to prohibit us from selling to foreigners, we're just not going to sell to anybody. Interestingly, then the grades came back together. So this is at least indirect evidence from as close as we might ever see in terms of a so-called experiment, that when marijuana was not as available, the grade point averages got better for these college students. Now, I sort of call that sort of short-term or intermediate effects of marijuana, but what about the long-term effects? There have now been multiple studies to look at what happens to teenagers that use marijuana heavily during their teen years, what's going on with them a few years later when they hit their mid-20s. And we see that those that use cannabis particularly heavily during their teen years are more likely to be diagnosed with depression, anxiety disorder, or to have suicidal ideation or suicidal attempts 10 years later. So a significant association with negative psychiatric outcomes just a few years later in these young adults. I want to spend a few minutes talking about the relationship of cannabis with psychosis, because this has generated a lot of interest and it is, of course, of great concern. This was sparked by an older study by Andreasen and colleagues in the late 80s that looked at cannabis use as was recorded in the records of those entering the armed forces in Sweden in the mid 80s. And what they found is that Swedish conscripts that reported that they had used cannabis more than 50 times, less than 50 times, compared to those only using it once or twice or not at all, were much more likely years later to be diagnosed with schizophrenia or other chronic psychotic illnesses. So this suggests a strong association of cannabis use during youth with later onset of psychosis. Now, we don't know from that whether these are people who were predisposed to both, but it certainly is a suggestion that cannabis is not a harmless product for certain individuals. We see similar work coming out of New Zealand. That's the Dunedin study that followed individuals from birth and showed that those who had used cannabis earlier than age 16, so by age 15, were much more likely to be diagnosed with schizophrenia or a chronic psychotic illness 10 to 15 years later by age 26, compared to those who started a little older. They were still more likely than those that were not exposed at all, but not nearly as much. So there may be something about the early exposure that's particularly a risk. The group out of the United Kingdom in London has been looking at the potency of marijuana and its association with these negative outcomes. What they call skunk would be a high potency smoked form of cannabis, and that those who use this high potency form of cannabis on a regular basis are much more likely to be diagnosed with psychosis. It may not be everyone, but it may just be those who have a particular genetic predisposition. So it may not be a general risk factor for the onset of psychosis, but it may mean that those who are already predisposed because of their genetic background or family history of psychiatric problems are more at risk for cannabis leading to later onset of psychosis. We see this work coming out of London being confirmed in other European sites, whether that's Amsterdam or Paris, where those that use the high potency THC products were much more likely to be diagnosed with psychotic disorders. So again, this is an emerging correlation suggesting a link between cannabis exposure, particularly early in adolescence, and particularly the higher potency forms, with very serious mental illness later on. I want to spend a moment just shifting gears and talking about the neuroscience, the brain sciences. And we do see that there are major differences in the brains of those that use cannabis compared to those that don't. These results are not consistent. So we see results kind of all over the place in terms of whether we see cannabis use positively or actually negatively associated with differences in different parts of the brain. So what are we doing to help unravel this difficult puzzle? Well, we've launched a very large scale study called the Adolescent Brain Cognitive Development Study that started out with 9 and 10-year-olds doing very thorough evaluations. So a developmental history, learning about what substances their mother may have used during pregnancy, learning about their early childhood experiences and any symptoms they may have of psychiatric problems or behavioral problems at ages 9 and 10. For the most part, very few children have been exposed to substances by ages 9 and 10. And so that's why we started then, both in terms of taking a history, understanding their background, as well as doing brain scans, an MRI scan of these 12,000 9 and 10-year-olds scattered all across the country. Now, our goal is not just to do this at baseline, but then to follow them with repeat evaluations every year to learn what's happening to them developmentally, how they're progressing in school, in their family relationships, and in terms of any psychiatric symptoms they may experience. But then beginning to look at what substances they begin to use during their teen years, because we know some of them will use alcohol, tobacco, cannabis, and other drugs, and correlating that with brain development by doing every 2 years a repeated brain MRI scan. So we're in the middle of our first follow-up. Actually, we were in the middle of this when the pandemic struck. And so we've had to slow down a little bit, of course, because you can't bring people in for voluntary research during the middle of a public health crisis like that. But stay tuned, because this study should help us unravel an awful lot about that brain development issue, where we know brains are different of people who use cannabis and those don't, but were their brains different before they started using cannabis? That's a very important question, because we want to know if cannabis and other substances are harming the brain, which is what we suspect, or are there differences that are pre-existing that can explain why they end up with different outcomes? So overall, we certainly know that the acute effects of cannabis can induce psychiatric symptoms and memory impairment. And I've suggested to you that CBD reductions, particularly in these higher potency cannabis products, may pose particular risk. And early adolescent cannabis exposure seems to be a major concern. Now, when we think about what we can do about this, I want to highlight for you the importance of prevention interventions. Here's just one study, and I highlight this because this one in particular has been part of a large-scale set of programs that can be implemented by communities. It's a family and universal-based prevention intervention for middle school students. And what we see is that those that get the intervention, that's the blue line, are less likely to develop cannabis use, at least by grade 12, than those that did not get the intervention. There also has been a summary or a comparison across all sorts of different family-based interventions that target parent-child interactions and strengthen family bonding, help parents develop the tools and behaviors so that they can provide both the love and nurturing that everybody needs, and particularly adolescents need, along with the appropriate levels of supervision and management that adolescents also need, and that balancing that parents struggle with every day. And so these interventions that target families can really strengthen families and reduce the onset of drug use over the ensuing few years. I think this is one of the promising areas for intervention. Not only does it show impacts, but it can be cost effective. So interventions like the Prosper intervention implementation delivery system can be very cost effective. So that's what I have for a key message today. Cannabis use has been increasing in prevalence, particularly among young adults and older adults, and it's the most commonly used illicit drug in the United States. Because it begins during adolescence, we're particularly concerned about any negative effects for adolescent use of cannabis, and these are significant. Cannabis can affect brain development. It certainly affects memory and cognition or brain health while it's being used. We know it has an impact on reward systems and motivation systems, and we don't want those hijacked so that youth end up being addicted to cannabis, and that may be particularly a concern when they're exposed early on. I hope the final message about prevention being effective when it's successfully implemented is one that we get across. You all as coalition members are well aware that we can have an impact on youth outcomes if only our neighborhoods, communities, and families will work together. And with that, I'll stop here. I'll stop my share and we'll open it up for questions. Now I've got a couple in the chat, but what I'd like you to do is either write your questions down and I'll see if I can read them, or go ahead and I'm not sure whether you can raise your hand or just unmute yourself and ask your questions. Okay, and Skyla asked, for the studies related to psychosis, is the substance lab tested? No, most of these are actually based on population studies. There have been some lab studies, and we certainly know that cannabis can induce psychotic symptoms when it's administered in a careful laboratory setting. So we have researchers like Cyril D'Souza at Yale University that have administered THC and cannabis products to look at their acute effects and sees an onset of serious psychiatric symptoms, particularly with higher dosages. It's absolutely true that when people buy cannabis on the street, they don't know what's in it. And so formaldehyde or PCP, that's the typical chemical name for angel dust, certainly can add to the risks. And that's true with all of these drugs that are used, is that the consumer doesn't always know what's in them. Can cannabis, Michelle McCauley asks, can cannabis be associated with an onset of anger? Well, in general, we don't see a relationship of cannabis use with violent behavior. The main substance that's associated with violent behavior would be alcohol. That's a well-known intoxicant that is associated with increasing aggression and violent behavior. While intoxicated, methamphetamine may also be associated at times with violent behavior. And there is, of course, there are individuals who may become violent while they're intoxicated, but on average, cannabis is not particularly associated with violence. Okay, Lisa asks, I hear people seek getting marijuana cards to help with things that bring people to ERs, like anxiety, psychosis, nausea. Nausea is one of the interesting things because people may use cannabis products to address gastrointestinal distress or upset stomach or nausea. And yet when taken regularly, it's actually associated with a very serious syndrome called hyperemesis. And so those that use marijuana heavily and regularly may be at risk of developing nausea and vomiting, even though there are times when they might think they're using it to treat their own symptoms. The data on use of cannabis or cannabis products for the treatment of psychiatric symptoms is either non-existent or extremely weak. And so, of course, I'm curious whether some of these chemicals in the plant might end up being useful for treatment of some of these conditions. And we want that to be studied. But I will say that there's a tendency for anything that's an intoxicant for people to look for reasons or what I think of as excuses to use that product. So you'll hear people saying that about alcohol. Oh, it's for my nerves. When what happens is that the product itself, when they stop using it or when they go through withdrawal, causes them to have anxiety or problems. And so it indirectly, the substance may be actually making their symptoms worse. And anyway, I think that's enough of an answer about that. Is there a spectrum of use or types that creates those ER admissions? Well, particularly the data from California, it suggested that the higher potency products, the shift to higher potency, and indeed in that situation, there also may be some where there are individuals who come there to use cannabis on holiday. We see this, I see this in Colorado and some parts of the West. And the high potency products may be particularly prone to produce overdose unexpectedly in those individuals. And what are the drivers to use the concentrates? Well, it's very potent. It's like, why do people use more potent forms of alcohol? Because they're looking for the high that they want to experience. Will the PowerPoint be shared? Yes, you're welcome to it. I made that clear to the, I really only finished finalizing it this morning. So it is pretty hot off the presses in terms of some of the slide development, but you're welcome to reuse any of the slides that you would like. DABs have become used in Rumford, Maine area. DABs usually that stands, usually means a wax or a concentrate that can then be, it's heated either with a blowtorch or with other material to vaporize it rapidly and then inhaled. That's quick version of it, but typically it's a very high potency extract of marijuana that's used in that manner. And Ildiko says she will post the PowerPoint. Thank you. Oh, there you go. It's already in the chat. I didn't know that could happen. Terrific. Well, those are the questions I have in the chat, but feel free to unmute yourself and ask anything else that's on your mind about this or any other observations about your local situation you'd like me to know about as well.
Skyla, I think she has her hand up. Did you still have another question?
No, I'm sorry. I was wondering if the cannabis that was smoked had been brought to the lab and lab tested to see if there were other components to it, and it was answered further along in.
Well, I will say that we have a hard time studying the cannabis that's used in the community. Cannabis is an illegal product, and so federal grants, those are the research projects that we support at the National Institute of Drug Abuse. You're not allowed to use our money to purchase something illegal, to conduct illegal behavior. Well, purchasing, possessing, or cannabis in the community is illegal under federal laws. So we have not figured out how to do testing of the cannabis that people are using in the community. There are some states that are doing this, but we haven't figured out how to do that on a widespread research basis. And it is something that we're trying to come up with ways to approach this by collaborating with our colleagues at the DEA. But at the present time, it has been a hindrance because we really don't know as much about what's sold in dispensaries or sold on the streets as we would like. And yes, the Dance Safe program was testing MDMA and other products at raves, but that certainly wasn't done under a legal and wasn't done using federal taxpayer dollars under a legal system. That was done essentially under the radar by a harm reduction group.
All right, any other questions for Dr. Compton today?
Dr. Mike Wardrop from DEA. I just want to share an interesting tidbit that I actually engaged in this morning regarding the federal system in our Northeast lab that does the testing of all the drug exhibits that we seize. And one of the nuances that have emerged are after the authorization of the Farm Bill, So marijuana exhibits that we're submitting to our lab, the different cannabis exhibits, we are seeing analytical products coming back of both conclusive and inconclusive. And for instance, a case in point, an exhibit with say 5 units, 4 of which were tested positive for marijuana, but 1 was inconclusive. That inconclusive, although it was marijuana, the THC content was below 1%. And as a result, they have taken the position that it's inconclusive and thereby it would not be cannabis for a smaller portion. And that would come into play when, for instance, you have immature cannabis plants that haven't matured to the point where they can produce THC. So it's right, sort of cutting edge, and it's going to impact potentially prosecutions nationally as a result of the Farm Bill. So it's one we're kind of weaving through.
Certainly, I have empathy for my law enforcement colleagues that are trying to figure a way through this complicated situation. And the Farm Bill has led to a number of nuances that I'm just reading about and learning about. Certainly, one of the things that has intrigued me, and I know very little about it, is that instead of Delta 9 THC, there may be a variant, Delta 8 THC, which is just slightly different chemically, still has intoxicating properties, but may fall under the safe haven in terms of the Farm Bill, in terms of quote unquote not being cannabis, but may be able, but still produces the intoxication, which is associated with regular smoked marijuana, and kind of forms a loophole. I think it reminds us that the cannabis is not one simple product or simple substance. And so that's part of the research that we're conducting, is to understand the different components and the impacts of the different chemicals in the plant, both to understand their abuse potential, the potential harms, as well as possibly some of the medical benefits from the different chemicals.
Thank you. I want to just add also that question on dabs. So, yep, you're going to see dabs in the Rumford area and many other parts of Maine. It's also known as shatter. And what the distributors or what the growers are doing is taking their marijuana shake, the loose marijuana leaves and such, and they're putting it under very high pressure with butane. The problem with that process is if it goes sideways, it's highly volatile and you're going to have a fire. You could explode the side of your house. It's going to put the tenants that are on the second floor in danger when they're doing this activity on the first floor. So it's, we see the marijuana dabs. It's like a wax. We've seized pizza boxes with it. It's waxy, as the doctor noted, and they break it down into really small pieces and they distribute it. But again, it's the process is as volatile as a methamphetamine lab. If the person conducting the activity doesn't know what they're doing, somebody really could get hurt.
When you use a word like butane, I think that becomes an obvious reason why there would be risk of fire in such a situation. And we're not talking about a little lighter's worth of butane.
And that's what we're seeing in the schools with the dabs and the vapes. That's how they can use it. They're vaping the dabs while they're at school.
Well, something I didn't present that I'm actually, in retrospect, sorry, I didn't include a slide on this, is we have seen a market increase in the vaping of cannabis products by youth across the country. And we saw that from about 2017 through 2020, a market increase. Most of the kids that are using it in a vaping form use marijuana in other forms as well. So unlike tobacco, where vaping may be the entry way into nicotine exposure and into nicotine addiction, in marijuana, the vaping use of marijuana vaping, while it creates some potential harms and very serious concerns, is mostly among youth that have already started using other forms. Almost always. That's what our data shows so far. There's a question in the chat about, do I have thoughts about the ESPER strategy for prevention intervention? Well, we don't have as much data on the effectiveness of screening brief intervention for youth as I would like, but the American Academy of Pediatrics recommends screening, brief intervention, and particularly if you identify a youth who has a significant problem associated with cannabis, alcohol, or other substances, making sure that they get that the treatment is started for them is a key benefit and is highly recommended. So you might check out the American Academy of Pediatrics for further information about screening and why they recommend it so highly.
Lisa Sander has her hands up.
Thank you. I just was wondering, after hearing more about the dabs, in addition to the process making it and the volatility of using it, does this butane also translate to some other damage within the body when it's used via, like the brain or other organs and tissues? Has that been studied?
Well, we do know that use of hydrocarbon inhalants can be extremely damaging to the brain and to lungs. For the most part, the risks, as I understand it, and our DEA colleague can help us understand this in more detail because he certainly has more experience than I do in this area. But my understanding and expectation would be that the risks are primarily in the manufacture, that the butane would really evaporate before it's being used. So by the time it's formed into a hard a hard crackly material or in a waxy material, butane has been pretty well extracted or evaporated out of it.
Yes, that would be correct. The end user would not be impacted by the butane. It's the manufacturing process and any extraneous people in the area that could be impacted by it.
All right, yeah.
And potentially the person that's actually engaged in it, unless he's wearing proper PPC while he's engaged in this activity.
Well, absolutely. Inhaling butane would be extremely bad for you, just like inhaling gasoline or toluene or other solvents is really bad for your brain. All right, well, I want to thank you all for your attention. This is, I really appreciate you asking me questions and in having some dialogue, which is not facilitated that great by a Zoom approach, but I encourage you all to speak up with one another and to learn. And if you have questions in the future, just send them my way and I'll try to answer them for you. There is one more in the chat that I'll try to get to. As more states legalize marijuana, possibly the federal government, how important is it to get information out to the general public? Well, I think that's essential. In the zeal to change laws and policies, very, very little information about the potential harms and downsides of exposure to these substances has been shared. And so I encourage you all to share this as widely as you can. That's why I'm always happy to partner with CADCA. How can you send follow-up questions? Well, I'm not hard to find on the web. And my email, here, I'll enter my email into the chat. That makes it easier than just saying it out loud. And I'm not too hard to find online. I'm pretty visible in the federal government. So there you go. Thank you so much, and good luck with the rest of your meeting.
All right. Thank you, Dr. Compton. Have a great day. We appreciate you and all the information you gave us.
My pleasure. Bye-bye.
Bye.
Thank you, doctor.
All right, everybody. So up next, we're going to talk about addressing the pills to heroin epidemic from a prevention perspective. And for that, I have CADCA trainer, Catherine Brunson. Catherine, take it away.
All right, we up and good? All right, welcome everyone. I'm so glad to be here because this is one of my favorite topics to talk about. I'm going to try to go through here pretty quickly. Briefly, we're just going to be discussing kind of, it's surprising to me in communities that when you say opioids, we're in the field, but outside of the field, a lot of people don't really even know what opioids are, and looking at the impact of the opioid epidemic. taking a look at pain reliever misuse, the extent of it, and opioid-related deaths in the United States. And the major focus for me is going to be on the impact of opioid prescribing. So opioids are just a term for drugs that bind to the opioid receptors in the brain. And these include illegal drugs like our heroin and fentanyl that you hear about, as well as our prescription medications like hydrocodone and oxycodone. So where the United States makes up less than 5% of the world's population, we consume over 80% of the world's supply of opiates. We consume over 81% of the oxycodone and over 90% of hydrocodone. And 4 out of 5 heroin users first started by using prescription medications. And the US opioid use has now surpassed our tobacco use in the adult population. That is amazing to me. So when we look at the opioid epidemic, and actually just saw a new figure out by the CDC that the number is going to be even higher thanks to COVID, but the still reported number is that we lose 130 people every single day in the United States to an opioid overdose. However, when we factor in all drug overdoses, that number goes up to 200 people every single day. And since 2001, we have seen an increase in our opioid use disorder by 500%. And the CDC estimates that the economic burden of prescription opioid misuse is about $80 billion a year. So every once in a while, I'll have someone in a training that I'm doing say that they don't know anyone and they're not impacted by the opioid use or addiction. And I always ask them, are you a taxpayer? It's impacting all of us. We still don't have the final numbers for 2020, but in 2019, we lost over 50,000 people to an opioid overdose. That's the equivalent of 309 fatal Boeing 737 airline crashes in a year time. So how did we get here? Well, way back during the Civil War, morphine was first used. Next, in 1898, the Bayer Company began producing heroin commercially. In 1914, Congress passed the Harrison Narcotics Act, which required a prescription for narcotics. In 1924, the Anti-Heroin Act was passed, making it illegal to sell heroin. Are you hearing this? So prior, you could buy and purchase both prescription medications and heroin legally. Then along comes Arthur Sackler in the 1940s, and he joins a medical advertising agency that became instrumental in promoting narcotics. His family financed and purchased Purdue Pharma. Then in 1970, the Controlled Substances Act became law. In the 1980s, the famous Porter and Jick letter was published in the New England Journal of Medicine, and it stated that addiction in patients treated with narcotics was very rare. Soon after that, the American Medical Association recognized pain as the 5th vital sign, and Medicare followed with a formulary to treat pain as a vital sign. This was really the critical tipping point for us in the opioid epidemic. Shortly thereafter, OxyContin was introduced and was aggressively marketed as a safer pain treatment by Purdue Pharma. It took over 10 years later and many lives ruined and lost before the feds charged Purdue Pharma for misleading marketing practices. Then in 2016, the CDC created opioid prescribing guidelines, and the American Medical Association eliminated pain as a vital sign. These were really key in us turning the tide on our prescribing rates. Following that, Medicare removes patient satisfaction for treatment for pain from the survey for reimbursement. And this was really critical. I remember early in my years of starting to address the opioid use epidemic, and I asked the head of our Trauma One Center, what did he think was really driving this market increase in use? And he said, Catherine, you need to understand, the CEOs of hospitals get their bonuses based on patient satisfaction scores. And they make sure to communicate that to all the physicians that are working in the hospitals. And so improved patient satisfaction scores came by patients getting more medications. So there are 3 waves, and what we'll discuss at the end is really a 4th wave now in the opioid overdose deaths. It started with prescription drugs, and from 1999 to 2012, we saw a continual increase every year. Among more than 81,000 drug overdoses that were estimated in 2020, the sharpest increase among deaths was from fentanyl and other synthetic opioids. It started with the prescription opioids, and then it moved to heroin, and now the dramatic increase is mostly attributable to the synthetics, primarily fentanyl. And as we'll discuss kind of towards the end, we are now seeing the 4th wave, which is stimulants coming into the picture. So to understand the problem in more detail, we have to look at accessibility. It doesn't matter what substance you're trying to address, whether it's marijuana, alcohol, vaping, or opioid use disorder. You have to look at where are the drugs coming from and where are they getting their prescriptions. So in this graph, you can see the accessibility of misused painkillers, primarily about over 65% are getting it at home, at their home or someone else's home. So it's much like alcohol. And so pain medications are usually coming from family or friends. They may not be given, they may be taken, but they're being illegally diverted to individuals. And so we see an important pattern with opioid use that we need to recognize is at the beginning stages, yes, they're getting it from their home or someone else's home, from family or friends. But as their addiction develops and carries on, then they begin to look at other routes of administration, as well as other ways to get their medications. So where they first might be just taking a hydrocodone or an oxycodone and swallowing the pill, they then begin to start crushing it and snorting it or injecting it to up the euphoric properties of it, because as they become more tolerant to those medications, they need to change the route of ingestion in order to reach that previously enjoyed high that they got the first time. They chase it and can't ever quite catch it. So 10.1 million people aged 12 and older misused opioids in 2019. If you haven't made plans to participate in the upcoming DEA Take Back Day, which is on Saturday, April 24th, I really encourage you to go to work tomorrow and make plans, because as you will see in a little bit, it's these pills that are sitting around our homes that are really one of the big drivers for opioid misuse, particularly amongst our young people. In order for us to effectively develop some interventions to address the prescription misuse, we need to understand the reasons that people are using these medications. So the majority of people who are misusing them, about 64%, are actually using them to relieve physical pain, which was the intended purpose. However, when the medications are not prescribed to you, then that becomes misuse. Other reasons that people report is about 9% saying to relax or to relieve tension. 4% are using it as a sleep aid. 4% to cope with their feelings or emotions. I'm always surprised by that number. I would anticipate that it would be a little bit higher. 3% to experiment or see what it's like. And 11% report that they're using it to get high. 1% are using it to increase or decrease the effects of other drugs. And about 3% report having an addiction. At this point, when they have a full-blown addiction, they're using more to really just keep from feeling what we call dope sick than the actual trying to get a high. They're really just trying to feel normal again. So heroin use has dramatically increased across the United States amongst pretty much all age groups, men and women, and all socioeconomic levels. Heroin use is more than doubled, though, among our young adults between the ages of 18 and 25. And again, 9 out of 10 of those individuals have polydrug use. And 45% of the people who use heroin were first addicted to prescription opioid painkillers. And I'm going to keep driving that point home, because it doesn't start with heroin. Heroin use is part of a larger substance misuse problem. So who is most at risk for developing a heroin addiction? Nearly all people who used heroin, again, used at least one other drug, and most used at least 3 other drugs. It's polydrug use that's really a high risk factor. Heroin is a very highly addicted opioid drug and has a high risk of overdose death for people that are using it. And people who are addicted to alcohol are 2 times more likely at some point to develop an addiction to heroin. With marijuana, they're 3 times more likely to develop an addiction to heroin. Cocaine, it's 15 times. And again, back to prescription opioids, they are 40 times more likely to become addicted to heroin. The overwhelming majority of heroin users previously report using those prescription painkillers. It just doesn't start with heroin. But this is also why sometimes, and I hear this in a lot in communities, people are like, why are you addressing underage drinking? Why are you addressing marijuana? And this is why we need to continue to address the whole spectrum of substances, because it doesn't matter what substance someone starts with, they develop an increased likelihood of developing a further addiction later in life. And so the incidence of heroin initiation is 19 times higher among those who are reporting this prior non-medical prescription drug use. Nationally, only a small subset of people who started using prescription pain relievers non-medically transitioned to heroin. The majority of people misusing opioids and heroin were polydrug users, and we've talked about this. And so this is why it's really important for coalitions to continue to work to try to delay that initiation of first use of any substance, really, by adolescents. Nearly 80% of all heroin users do report that prescription opioid use was where they started. And so as we work in our communities to address prescription drug misuse, we need to be prepared for individuals to switch to the cheaper and easily available heroin. As individuals begin to develop a chemical tolerance to prescription medications, meaning that they have a dampered euphoric effect over time, they need a stronger drug to get that previously enjoyed high that they were getting from those milder drugs that might have just been taking a hydrocodone pill. And so as we do the work that we do in our communities to work with practitioners to reduce their opioid prescribing, and the prescription drugs become harder to get, heroin steps in and is a cheaper and better high. Its purity, cost, and availability, they really are the drivers of all substance use. And so we've seen a lot of progress in the United States since 2013 in our opioid prescribing. However, it's still really, really high. The US is the #1 consumer of opiates. And our opioid prescribing rates are still greatly contributing to the opioid epidemic. So it's really critical as coalitions that you're collaborating with your healthcare partners in your community, which has been very difficult when they're busy with COVID. So when we look at geographic trends across the United States, you can see that there's a lot of variation in our opioid prescribing. It's more concentrated in rural areas as well as in the South. The top 3 states, Alabama, Tennessee, and Arkansas. I've known this for a long time. I'm in Tennessee. We had enough opioids prescribed to have every resident have approximately 70 pills each. The state with the lowest number of opioids per capita is Hawaii, with the equivalent of approximately 26 pills per person. So rural areas, it's important to note, are sometimes especially hard hit by the opioid epidemic. Frequently, there's not a hospital or provider in these rural communities. And so when a physician or practitioner knows that you had to drive an hour to get to their office, they might have a tendency to prescribe a few more pills than necessary to make sure that you've got what you needed so you don't have to come back as quickly. So overprescribing in surgery in particular is really fueling and contributing to the opioid epidemic. 99% of surgical patients receive opioids to manage their post-surgical pain. And the average number of pills that are prescribed after surgery is about 82 to 85 pills. Nearly 3 million individuals had surgery in 2016 and became persistent opioid users. The majority of those, 2 million, were women. Overprescribing of opioids after surgery resulted in 3.3 billion unused pills in 2016. I'm going to say that again. Overprescribing of opioids after surgery resulted in 3.3 billion unused pills in a single year. The average number of opioid patients, the average number of opioids that people receive after surgery varies very widely, from about 45 pills for a hysterectomy up to almost 200 pills for someone having a sleeve gastrectomy, which is the weight loss surgery. So on average, again, 82 to 85 pills are prescribed to help manage that post-surgical pain. And while there is some evidence that limiting access to prescription opioids can lead people to street drugs such as heroin, that's not a major concern when we're talking about treating acute pain from surgery. There was a study done by Stanford University, and they found that curtailing the number of opioid pills for patients with chronic pain could lead people to illicit opioid use, like buying the heroin on the street. But reducing the prescribing of opioids for acute pain actually had quite the opposite effect, and it helps prevent overdose deaths and addiction. So when we look at who we might want to target first in our communities, you might want to keep some of these prescribing rates in mind. But for us that are working in community coalitions, and particularly focused on adolescent use and trying to prevent that initiation and that first use, you might want to think about who's most likely to be prescribing to our young people. And that's usually the wisdom teeth surgery, so a dentist and oral surgeons, or the orthopedic surgeon, because you've gotten a sports injury, you know, from playing football or whatever sports you're playing in high school. So there are a high number of patients who report having unused opioids after surgery. As I said, we had 3.3 billion in 1 year. And this really greatly contributes to the misuse of opioids if they're not disposed of properly and promptly. So we don't want medical providers to not prescribe to treat pain, but perhaps prescribe fewer quantities of those pills. Additionally, this overprescribing quantities of pills for surgeries has a significant impact on contributing to the misuse and the overdose epidemic. 9 in 10 surgery patients with leftover pills admit that they keep them in their home. They share them with their family and friends and do not properly dispose of those medications. Nearly 50% of the 45 to 54-year-old patients keep their leftover pills at home. And while that data show that surgeons are prescribing more pills than the patients need, about 66% report that they feel pressured to prescribe more pills than they know that the patient actually needs. But this is at the core of the DEA take back dates that we're trying to do. So I hope everyone is planning to participate, because we need to make sure that we're getting the message out about getting these unused pills out of the home. Of particular importance to coalitions too is the focus on the adolescent use. Teens who receive that prescription for an opioid medication, again, it's usually from a wisdom teeth or an orthopedic surgery. If they receive an opioid prescription by the 12th grade, they have a 33% increased risk of misusing opioid medications between the ages of 19 and 25. And among those that normally would have very low predicted future use, if they had an opioid prescription by 12th grade, they had a 33% increased likelihood of having an addiction later in life. And it's a 30% increase in likelihood of having a heroin addiction by the age of 30. So opioid pills do contribute, prescribed after acute surgery, do contribute to long-term use in some patients. 1 in 15 patients who receive painkillers after surgery do use them long-term. And taking opioid medications for just 1 day increases the risk the patient will still be using that medication a year later by 6%. An 8-day consumption of opioid medications increases the risk by 13.5%. And taking opioid medications 31 days increases the risk of using that drug at 1 year to nearly 30%. Duration of the opioid medication has a large impact on whether or not someone will still be using that, misusing those medications long term. So I also like to bring up that adults who receive higher doses of opioids are also at increased risk for suicide. And the more regular that they misuse those opioids, the more likely they are to engage in suicidal ideation. Furthermore, of those who have a diagnosed opioid use disorder, they are 13 times more likely to die by suicide than the general population. Higher doses of opioids actually increase access to a lethal means. And additionally, opioids have a disinhibiting effect, meaning that someone might be more likely to act on their suicidal impulses. Fear is a very protective factor, and it gets diminished with the use of opioids or alcohol or other substances. So I really am encouraging coalitions. Substance use and mental health and suicide are so very interrelated. And in most communities, they're not coalitions funded to be able to address both issues. So I really encourage coalitions to consider not having to do a bunch of new strategies, but to incorporate some suicide prevention messages into your already existing strategies. Where we're losing 130 people every single day to an opioid overdose death, we also are losing 132 people every single day to a suicide in the United States. And those numbers have been increasing as well, steadily, along with the opioid prescribing starting in 1999. At the same rate, our suicides have been increasing since 1999 as well. So we were beginning to see some improvement with the opioid epidemic when the coronavirus hit. And now the coronavirus has presented some new and unique challenges for all of us that are trying to navigate these waters. So it's really important we find ways, even though we're operating, in this Zoom environment, this virtual environment, to make sure that we're still staying vigilant in our efforts to address the opioid epidemic, because we've seen a dramatic increase in both our overdose rates and our suicide rates during COVID. So in March of last year, the World Health Organization declared the outbreak of the pandemic, and nearly 95% of us were under lockdown, with more than 1 million cases worldwide by the 1st of April. Then the CDC told us to wear our masks, to social distance, to limit gatherings, which caused widespread fear. Fear of catching the virus, fear of the future, fear of the unknown, fear of not knowing how to cope with this anxiety and these feelings that we're having. And so it really presented some real big challenges for us to try to continue to address substance use disorders with all these mental health challenges that were taking place. This fear, stress, and isolation and hopelessness that many Americans have experienced really have increased the number of drug overdose that and the suicides that we've seen. Nationwide, our overdose rates have been climbing over the past year, putting 2020 on track to be the deadliest yet for our drug overdoses in the country. So with this increased mental health and stress that we're experiencing because of the COVID and the lockdown and the loss of connections with our fellow human beings, the increased stress leads to an increase in substance use. And so there was a report done last June where adults reported about 31% said they had anxiety and depression symptoms. 13% started or increased their substance use. 26% had trauma or stressor-related disorder symptoms, and 11% seriously considered suicide. So if that wasn't challenging enough, now we have stimulants entering as the fourth wave of this opioid epidemic. We know that most overdose deaths involve polydrug use, and the 10 most frequently occurring opioid and stimulant combinations accounted for over 75% of the overdose deaths. Fentanyl is in everything. There is not a substance that has not been found to contain some fentanyl. Drug overdose rose approximately almost 28% in the United States in the 12-month period ending August 2020, according to a very recently released data set. And so what is the fentanyl? The fentanyl is a synthetic opioid that was currently listed as a Schedule II prescription drug, and it is 50 to 100 times more powerful than morphine. So the reason that we're more overdoses, it's that much stronger, so it's much more likely to kill you, to cause the death. It was originally intended to treat cancer patients, but now it is increasingly being sold on the streets almost everywhere. And again, I actually do a lot of harm reduction work as well. There's not a substance where we've not seen it pressed into. We've seen it pressed into Xanax, Valium, Percocet, literally almost every single substance. And so it's important to know if you're out in a community and you come across a substance and you don't know what it is that this fentanyl can actually be absorbed through the skin or eyes and mucous membranes pretty easily. So I always caution people, all this hand sanitizer that we're using with this high alcohol base, that actually, if you would use a hand sanitizer after coming in contact with a substance, would actually increase the absorption rate. So you never want to use hand sanitizer if you come in contact with a substance and you're not really sure what it is. You want to use some good old-fashioned soap and water. So we also, in particular in Tennessee, there's a county right beside me where 71% of their overdose deaths last year contained methamphetamine. Methamphetamine also had some fentanyl in it. But the methamphetamine that's being floating around right now is, as you can see, dramatically more pure than the mom and pop methamphetamine that was being, cooked up with some pseudoephedrine in the backyard. It's highly, highly pure. And so as we work on reducing our prescribing rates, and then so people then switch to that heroin, well, if they can't get their hands on the heroin, the methamphetamine right now is cheap as dirt. And so it is very, very prevalent in Tennessee. We have seen about a 75% increase in our treatment admissions to state facilities for methamphetamine in the last year, and over 25% of our overdose deaths are attributable to methamphetamine too. And so it depends on where you are geographically, whether it's the stimulant is cocaine. We see that cocaine a lot more on the West Coast. In my area, it's a lot more of the methamphetamine. And so because of all this opioid overdose deaths, we have actually counteracted all medical advances in our entire lifetime in the last few years. It's actually the last 3 years now where our life expectancy has decreased. And that's never happened before. And it's just crazy to think about with all the medical advancements that we have. So in order to develop your strategic responses, you need to understand who is most at risk. And this is pretty much standard no matter what substance you're addressing, whether it's marijuana or vaping, is you need to look at individual level factors like the mental health, the physical health, whether there is substance misuse, what about education, employment, religion. There's a whole lot of factors that we look at in individual level factors. Then we want to look at relationship level factors. Do they have family members might be using? Do they have peers that might be using? Are they hanging out in social networks where there's active drug use? Community level factors. Homelessness is a huge factor that we're seeing right now, but looking at the living arrangements. Workplaces is not much of a factor anymore, since most of us are still operating in a very virtual environment, and that's particularly true with a lot of our schools still. And then community norms. As Dr. Wilson was talking about, with the state, after state adopting marijuana laws, it really changes those community norms around acceptability. And so we have to think about that as well. And also looking at trauma type issues and discrimination and socioeconomic status. And again, COVID just fits perfectly into all these factors that are increasing the likelihood of both substance use and suicidal issues. And so populations that are at the higher than average risk for opioid misuse, dependence, and overdose are polysubstance users, women, the elderly, young adults, and individuals in recovery. So I would encourage you to think about who serves these populations in your community and reach out to partner with them. As I stated several times, the opioid prescribing really was at the root and the heart of developing this opioid epidemic. And it's still going to be critically important to be collaborating with the healthcare community. And so thinking about providing some prescriber and patient education around the benefits and opioids, around unsafe opioid use and strategies to address it, expanding patient use of alternatives to opioid treatment when appropriate, and improving patient access to opioid overdose antidotes like the Narcan, the naloxone, and treatment for substance use disorder. Patients also say that discussions about the dangers of opioid use is not happening in the doctor's office, as well as discussions about alternatives. And so this is another area you might want to really consider providing some messaging and resources to reach consumers while they're in the physician's office, which can also educate the practitioner as well about the dangers that do exist and about asking your provider for alternatives to opioids when appropriate. There's some pharmacological and some non-pharmacological methods that can be used depending upon the type of treatment that needs to occur. So some other community partners that you might want to consider, the Department of Children's Services, very frequently, they play a role because of child abuse or neglect that's based on substance use that's occurring in the home. Department of Human Services, and in the coming years, they're going to become even increasingly important partners in prevention, since these departments are in most states responsible for the Medicare and the Medicaid programs or any other state health insurance programs. And under the Affordable Care Act, these programs are mandated to provide certain prevention services at no cost. So if you haven't considered reaching out to them, I'm sure they would probably welcome it. Department of Motor Vehicles, again, they have funds through the Office of Highway Safety that address drunk or drug and driving prevention programs. So that's another place to think about where you might want to try to reach people. Thinking about your elected officials who have the power to provide some legitimacy really to your substance use issues and how it's impacting your community. Maybe even a little funding as well might be a good thing. Looking at who's serving these high-risk populations, looking at your community action programs, your shelters and your food pantries. Do you have a domestic violence or mental health coalition in your community? Working through employers and senior citizens programs or recovery organizations. Veterans and military organizations as well have larger experiencing substance use and misuse, as well as mental health issues at a higher level than a lot of other demographic groups. So that's another group that you might want to reach out to. And I have to say, they also are incredible volunteers, as well as groups like the National Guard. They are wonderful resources to coalitions. So thinking about how you can expand the many sectors and partners that you have around the table. I've always said, I don't care what issue you're trying to address, you will achieve a reduction in substance use if you spend a little more time on building your collaboration and your capacity in your communities, and I think sometimes we tend to focus on that youth risk behavior survey or the PRIDE survey and how are we going to reduce those numbers. And I'm a firm believer from someone who's been in this field for over 20 years, that if you spend just as much time focusing on building those collaborations, those relationships in your community, the reductions in substance use will happen. And so I just put this slide in as sort of a placeholder to say, the CDC has got over 20 or 30 infographics and graphics that you can download and use. You don't need to have a graphics department or anything formal. The National Safety Council as well has an opioid prescription toolkit that is just excellent. Both of them have infographics that you are allowed to copy and share as long as you credit them. And so there's tons of materials for news releases that you might want to do, op-eds, just a whole lot of resources where you don't have to necessarily come up with the content yourself, as long as you're crediting these resources. And so that was a whole lot in a very short amount of time. So I am going to stop my share on that one and open it up in case anyone does have any questions or anything that they would like to share with us. And is there a glob in the chat? I've not been following it along.
Catherine, the only thing we had in the chat was we did have Michelle asking if we can post the presentation in here, if you have it handy.
Actually, it is one of over 500 slides because this was like a training that I took and tried to condense. So if I can, I will file save as after this and send it to you, Adilko, if you can send it out. But it's
No, absolutely.
It was for a week training, so I tried to just plot a few slides, but I didn't actually separate it. But I can separate it and send it to you.
Sure, perfect. Thank you.
Any other questions or comments? Anything y'all want to share from your own work that other folks might learn from?
Kathy, I just want to say thank you for putting the plug in for Drug Take Back. Just let everybody know where to go. We have, I believe, 133 agencies ready to go in the state of Maine. We have one of our prime lead mentors. He knows I'm looking at him right now. Mr. Chief Mike Hagan from Caribou PD. I got into this game and he was ahead of it decades. He's one of the leaders in this game in Aroostook County. We've been very successful in the state of Maine, and it's really on behalf of the commitment by the police departments, but truly the communities making it work. But unfortunately, we just have way too many pills in this state, and we just keep collecting more every collection. I used to think it was a good statistic, but it really isn't. Every drug take back coordinated by DEA for the last decade, Maine has had the #1 collection per capita, which I used to think it's just because of the volunteerism and everybody's stepping up, but I'm seeming to think that we just have way too many pills. But the efforts are going April 24th. So everybody, use your Facebook accounts and get the word out, because we are ready to go and with all these different agencies.
Yeah.
If you've not made plans, I really do encourage you, because as I was sharing the number of pills that are left over and then people keeping them in their homes, if we really want to prevent that initiation of use by our young people, we got to get those pills out of the house.
I posted the takebackday.dea.gov in the chat. You can find more information there, and it has a local drop-off sites locator on there, so you can go and see where you can do the medication drop-off.
Yeah, we got every corner covered. I took the opportunity to talk with JD Spark, the new chief in Lincoln PD. He's a go. He just came up here from Texas, but he's excited to join the team. Now I have confirmation from our 2 chiefs at our tribal communities, Passamaquoddy in Pleasant Point and Indian Township, and they are also a go. So across the board, we have true commitment to move this thing forward on the 24th.
Mike, how do you sign up for that? I work for an agency in Somerset County, and we were just interested in possibly, maybe not this quickly becoming a part of it, but for the next one.
So the drug take back, it's teaming up with your law enforcement partner in the community.
Okay.
Captain Carl Gottardi at Somerset SO. We talk all the time. He's the point.
Okay.
Skowhegan PD, and the partners in Somerset County. But really, your contribution is just engaging the coalitions, engaging the schools, all the community partners. If anybody has one of those neon signs along the way, I know in Skowhegan at the car dealer, they have a neon sign. See if they can rotate it and pivot to drug take back versus buy our car.
I like that. I like that. Thank you.
It's a great place as people are just pulling up and dropping for you to provide resources or information, about the work that you do in the community to help engage people, but to provide those prevention messages. Where I am, we've put together with United Way a whole bag of resources. So every person that pulls up with their bag of pills, we're going to be handing them a whole bag of community resources.
Yeah, it's really get creative. I know Troy Morton, the sheriff in Penobscot Sheriff's Office, and Kevin Joyce with Cumberland, although they're not doing it this time, but generally will have a shredding service also at those locations to allow people to come in and shred all their important documents. And I know during one of our collections, we also had a donation of food so that we could have the medications drop, but also people could drop off food products so we could fill up and provide those less that needed the food, they could have it. So get creative. It's your project. It's your community.
I don't know if every police station is like ours, but we can drop them off anytime during the year. They have a box to put them in.
Yep. Yeah, correct. I think there's about 80 some odd agencies throughout the state of Maine with the collection boxes in their lobbies.
Yeah.
So it's a great service that these police departments offer. It's outside of their normal routine, their book of business. They have to make extra space in their evidence rooms to consolidate and store and secure. But again, they're committed to being a partner, and everybody can contribute. What can anybody do? Go to their medicine cabinet and get rid of it. If it's old, expired, unwanted, don't save it for a rainy day. Drop it off on the 24th, no questions asked.
All right. Any other questions for Catherine? If not, I will turn it over to Erica for final thoughts and to close us out.
All right. Well, hello, everyone. Thank you all for attending. I do hope that you found this summit helpful. We covered some very powerful topics here today. Some of it could be very hard to discuss, but it is necessary to discuss. I also like to quote Barack Obama, who said, let me see if I can get this right. Change will not come if we wait for some other person or if we wait for some other time. We are the ones we've been waiting for. We are the change that we seek. So I hope that you can take what you have gained here today and yesterday, make the changes we need to make and make this world a safer, healthier life for our future. DEA 360 is really committed in collaborating with local prevention groups, schools, community organizations, really anybody that wants to work with us in providing free resources, trainings, and educations throughout Maine. So please, I put my information, my contact in the chat. Please contact me if you have any ideas on what we can do. I would love to collaborate with all of you. And one of the other things that we are also doing is doing previews of a documentary, If They Had Known, which is a film about casual use of drugs and alcohol. It's about a documentary of a young man who has an accidental overdose from using alcohol and Xanax. It's not about addiction. It's not about substance use. It's about that casual use of drugs in the party culture among youth and young adults right now. So it's a really powerful, it's a great film. I'm doing some previews throughout April. I put the flyer on there if you're interested. Like I said, give me a call or contact me. And then before I let you all go, I just really want to thank our partners who put this together: CADCA, Somerset Public Health, Healthy Sebasticook Valley, and Aroostook County Action Program. Without their input and expertise, we would not been able to put this together. So I really appreciate their help and thank you so much. All right, and I'm going to give it back to Doug and he can close this out.
All right, thank you very much, Erico. You know, Erico, I'm gonna just say ditto. I mean, I want to thank everybody for participating. I want to thank everybody for helping plan this and make this an event. I hope that you take this information and continue to work on reducing substance misuse and use in your communities. Thank you very much for your time today and tomorrow. Take care, everyone.
Bye. Thank you.